So I did put, hey Sarah, good morning. We're actually today going to speak a bit about some image optimization techniques, some knobology and what it means, where to find these resources, how to use the ultrasound machine, and what are the different like parameters on the ultrasound machine. So just we talk about the same language. Uh, so a lot of the information you're obviously going to be able to go back, like you'll have a section here in pro position and knobology, and I've put a few resources, including already a video where I go over the machine and some of the parameters, and each machine will obviously have its own parameters, but they all kind of come with the same functions in general. So the machines we have at the Montreal Children and the Jewish actually and Saint Justine Hospital for you, Laurence, is the Philips and the GE Venue Go. What you'll be using in cardiology is the GE Vivid E95, but they all come as their same principle. So let me open and see if I have a keyboard. So I'll show you an example of some of the keyboard function that you'll see. The way the Philips function is that you'll have in the middle of the keyboard this
Yep.
little ball, which serves you to move around either your cursor, your line of interrogation, or your mouse if ever you're clicking here and you're using the pointer. And then within the first few elements that you'll see that there's a button here, a button here, a button here. So they really act like a bit like a mouse in the sense
Mhm.
that on the screen, when you're actually imaging, let me see if I have an example somewhere of a screen. I do have an example. So you see the keyboard is like kind of this thing here, and you have this part, which is a touch screen here,
Mhm.
and then you have this screen here, which is not touch screen. And then you have one first line of button, a second line of button, and then you have here something called the TGC, which is your gain that you can adjust on a horizontal fashion. So if you move this to left or right, left means less gain or more gain, and it will change the gain only on the upper part of the screen. Versus if you move the lower portion, will change the gain only on the lower portion of the screen. So you can, on your own image, adjust to have
Mhm.
less or more gain, which is the amount of amplification of the signal, so that you kind of increase, quote unquote, the brightness regarding certain structures, which may be in the
Mhm.
middle of your image or in the background of your, like the bottom of your image. So let's say you're doing a parasternal long axis and you would really want to kind of increase just your gain around the mitral valve. You might use the lower portion to increase the gain by increasing it towards the right side. And if you're looking at more coronaries, you may change the gain kind of in the middle if you're like in the middle of your screen in your parasternal short axis. So that's kind of this part of the table. The other thing I want to show is, yeah, here I'm doing an echo on myself. So when you're doing an ultrasound, you see that you have a sector width, and obviously you want to probably narrow your sector in order to have whatever you're interested in. So things that you can do to optimize your image are obviously to zoom on the structure by either adjusting the depth, so how far are you going into your image, and often the actual machine will tell you how far your depth is. So here you see 15 centimeter on the screen. It means there's 15 centimeter from the probe to the end of your pie chart that you're obtaining the image. You'll have a focus on the side of your image, which you can adjust with the button here. So you can bring down or up your focus, and you can also narrow down your focus, which means the actual ultrasound energy will be sent really into like that area of focus the most amount. Um, the other thing that's important to do when you're optimizing your image, so you can change your sector width. It's often this button that's here or here. I can remember it's one of those. And then the depth is here. So sector width and depth. And the more you're going to adjust it, the more you're going to improve what we call the temporal resolution. Temporal means time. So you're able to obtain much more frame per second if you have a much more narrowed image. These buttons will correspond to the selection on the screen here. Okay, so at the button here, if I click this button, it will bring my selection to this. If I click back this button, it will bring me my selection here. And if I just click this button, it's, especially if you have multiple choices, it will go from this side to this side to this side to this side, versus this one, it's going to go the other side. I don't know if you see what I mean, but let me show you an example here. When you are in color, so here I've opened my color box, you can see that you're going to have like the box position, the box size. You're going to have the 2D position because your actual pie chart can move around. So it's like a camera that you move to the left or to the right. So you could move the 2D camera, or you can move the actual color box. So if you click here by going on this button, it's going to appear yellow. You'll be able to move the box around your image. And if you actually select box size, you're going to be able to increase or decrease the size. If you change, you can change the 2D position, or then you can go and select your cursor, which is like kind of your line of interrogation. Okay. So let me go back to this quickly. So for the keyboard on the Philips, you'll have these buttons that are quite important to do these actions. You'll be able to select some of the labels. You'll be able to get access to your measurements from here. And then these buttons, freeze means you're taking a still frame, versus acquire means that you're acquiring your image. And so we typically will acquire loops. And so you'll able to select whether you want to acquire loops based on time in seconds. So here you see that you have a loop length, or you can actually use what we call beats. So instead of time, you can select beats if you have your ECG gating, and you can say, I want to, acquire based on 3 beats, 2 beats, 4 beats, 10 beats, 12 beats, up to 20 beats. And you want typically longer loops if you're going to be doing sweeps, and shorter loops if you're just going to be doing like a focused view on a particular structure, such as the left ventricle or the right ventricle. Now, this is the screen that will typically appear on what I showed you to be your touch screen on the machine. And whatever is appearing here at the bottom of the screen will have button in fronts. And these buttons mean that if you click on that button, you're going to be acting on whatever selection you have here. So for example, if I click either on the touchscreen M mode, it's going to be doing the M mode. If I click on the actual button under it, it's also going to do an M mode, basically. On your touchscreen, you can select your probe on top, which is basically following the order of where you plugged your actual different probes. And then within your probe, you're going to be selecting the different presets that you would want. These presets have been calibrated typically on whichever, preferred imaging you locally have selected. So our presets were organized with a technologist from Philips who came in, we scanned, and we decided that these were the images. But be very careful because, for example, I see Sarah is on the line. On the GE Venue Go, some of these presets have been very much selected to be very specific to, for example, veins or arteries or pulsation, or kind of to optimize also the flow of the imaging that you're going to be acquiring. So if you're going to be using a preset to always image veins, for example, then obviously the type of color filter velocity is already going to be pre-saved to be at a lower speed than if you were be doing an artery, which is typically a faster speed. So instead of like each time manually readjusting everything, your preset has already been saved to kind of do whatever purpose you have for that preset. So if you're going to image a vein, you typically want to have lower velocities. You want to be able that when you're going to be acquiring the Doppler, this Doppler is going to be calibrated, that it's going to have a scale that will show you these low velocities, versus if you're going to be doing arteries, you're going to be using a higher velocity, and some of these presets like a pulse wave Doppler or continuous wave Doppler will already be calibrated so that when they appear, they're already saved so that they show you a scale that represents higher velocities. Okay. We're not going to go into tissue harmonics, dynamic range, all these things you can read. This is a bit more advanced application. Okay, so this is the keyboard of the Philips. If it opens one day. Yeah. So when I told you that some of these these things at the bottom of your touch screen, they're going to appear here. And each of these buttons will correspond to whatever is appearing on the touch screen. So for example, in that particular preset, if I click on this button, it's either going to go on X-res. If I re-click, it's going to select 2D opt-res. And then it's by turning the wheel that I can choose which of the options I want in this particular preset, which is not something you're going to play too much with. I've put some explanation of what is 2D res, what is 2D opt, what's X-res. You'll be able to read on it. It's really in ways to optimize some of the subtleties of the image acquisition, specifically on the Philips. But if, for example, I click on this button, so the button here, it's automatically going to select my M mode. And if I take this wheel and this button that is in front of M mode and I turn it, it's actually going to change the gain of my M mode. Okay. Same thing. Here you have some wheels that are the most classical wheels you're going to be using when you're scanning. So we mentioned the depth, we mentioned the focus already. We have the continuous wave Doppler. So you always will do your 2D image, then you acquire this, then you put your color, you acquire this, then you align your cursor on the color where you want to do your Doppler, for example, and then you click on your Doppler. When you click on continuous wave, it's going to capture the velocities across the entire line of interrogation. And you can use this wheel to either decrease the gain of the continuous wave or increase the gain of the continuous wave. So gain is not necessarily just about the 2D image or the bidimensional mode or the B mode imaging. It's also about increasing the intensity of the signal that you may get by Doppler, for example. So you can increase your gain on CW, you can increase your gain on PW, you can increase your gain in color, which will amplify the signal of the actual color or amplify the signal of the Doppler. Okay. These options are also available on the GE Venue Go, but it's much rarer that we're going to be playing with the gain. So you'll be using CW, you'll be using pulse wave Doppler, you're going to be using color, but you're not necessarily going to change the gain because it's mostly like in some of the cardiac applications that you're going to be doing this. If you want to change the gain of your entire image in B mode, you're going to be turning this wheel. So if you decrease, it's going to decrease the gain of the image overall. If you increase or turn it right, it's going to increase the gain overall. As I mentioned, if you just want to increase longitudinally or horizontally the gain of specific areas, then that's why you have these different right and left buttons that you can adjust so that so if you would put this one completely to the right and this one completely to the left and this one completely to the right, it would do like a zigzag on your screen, a bit like un code barre à l'envers, like a barcode, like reverse. So CW is to obtain a velocities across an entire line of interrogation. It's typically something we'll use for high velocity things. So you want to make sure there's no obstruction through an artery, through a valve, coarctation, a PDA, a VSD. Pulse wave Doppler is something you're going to want to capture the speed in a very discrete area of your anatomy. So I'm interested in looking at the speed of an artery. Or I'm doing an art line, like for you, Sarah, you're doing POCUS, you're doing an art line. You want to make sure you're in the artery and you're not in the vein. So you want to see the pulsation. So you're gonna use what we call pulse wave Doppler, PW, which means it's going to take the instantaneous velocity in that particular place on the screen or wherever you've put your actual cursor. So it's not the entire line that is subjected to get this information. It's just really the point of interrogation. So if I show you an example, I can actually try to show you on the GE Venue Go so you get a sense. Cardiac focus example. So this is in M mode. It's really getting, you see here, we're putting the line of interrogation, and as the time advances, it gives me whatever is appearing across this line of interrogation, and this is on the GE Venue Go. That's particularly important to see like motion of certain structures, for example, or how far they displaced or moved around. So we can do pulse wave Doppler. Pulse wave Doppler, you'll put your line of interrogation. Here, we're getting a pulse wave Doppler at the right ventricular outflow tract. So you have RVOT. Here, you probably have your pulmonary valve, and eventually you divide into your left pulmonary artery and right pulmonary artery. That's your parasternal long axis view. And when I put this cursor here, what the machine will give me is the speed of blood flow. So this is the speed in meters per second, and this is time. So it tells me exactly here in that particular area, which is at the RVOT, this is the speed and this is time. So you can do this for various structures. So we'll typically do it in, for example, the pulmonary artery. We'll do it in the inflow portion of the ventricles. We'll do it for pulmonary veins. So that's an example of a pulmonary vein. This is the inflow of the left ventricle. So you see that there's like bunny ears because we get an early phase and an atrial kick or active phase. We'll often do it in like outflow tracts, like for example, for the LV. So this is an example here. You can do it in coronaries. And then you can do it on tissue. So you see, this is on tissue. So here we're obtaining the speeds on the tissue of the septum. And here we're doing it on the lateral of the left ventricle, which tells me the speed of how this muscle tissue is acting in systole and how it's acting also in diastole. And in our first course, Laurence, we reviewed kind of these concepts of tissue Dopplers for this piece. And you can do it also like if you're looking at aortic flow. So this is like an arch view where we see the ascending aorta, the transverse aorta, the descending aorta, the abdominal aorta. And you can capture, for example, the descending abdominal aorta to get a sense what's happening in my flows. And that will be particularly important if you want to rule out that there's kind of retrograde flow or steal effect from like a duct structure or any kind of other elements that could cause reversal of flow in diastole. Can you name me like a few differential diagnoses of reversed and diastolic flow? You're muted. So any reason why you would have holodiastolic retrograde flow in your aorta?
Holodiastolic retrograde flow.
Why would flow go backward in diastole in the aorta?
Well, we talked about the PDA, that's
Of course.
significant.
So left to right duct with low PVR relative to
Yes.
SVR. So then you get in diastole the steal because the SVR are higher than the PVR. So it's going to steal via this ductus arteriosus. And so you get this retrograde flow into your aorta. Okay, so that's one first reason.
Then isn't it possible to happen with like how do you say like tronc artériel commun?
So truncus arteriosus,
Yeah.
absolutely.
Yes.
So in the international nomenclature, it says that we call it common arterial trunk. So in common arterial trunk, there's multiple conformation and classification, but typically you have a vessel that contains the combined ventricular outputs, and then this will branch out into different anatomy or conformation. But basically, the physiological effect is that you have pulmonary arteries branching out of this massive vessel that will eventually also branch out into your kind of ascending, descending aorta. And so you get a steal because your PVR might be much lower than your SVR. What else?
Wait, I'm just trying to figure out if hypoplastic left heart does that as well.
So hypoplastic left heart often, so
But
any kind
I'm
of
not, yeah.
Yeah, any kind of congenital heart defect that has a big PDA that is maintained artificially, right?
Yeah,
So
can actually happen.
you could have a tricuspid atresia or a HLHS in which
Mm-hmm.
you're actually giving prostaglandin and in which your PVR are lower than your SVR, and it's because you have a duct that's stealing into your pulmonary circulation. Okay, let's say you don't have a duct. What other kind of lesions could be causing you this that you would have to think about? It could be other people that helps out Laurence.
So let's say you have like your body is trying to get the blood from the systemic circulation, like from the head, let's say.
Vein of Galen. Yeah. No?
So when you have vein of Galen malformation, it's an AV malformation, often AV, well, it is an AV malformation that will steal. It's like a kind of a aspirateur, like you're sucking all the blood. So you don't have to have a duct. Actually, often they have right to left ducts, right? Because they have so much sucking effect that they're almost what we call a pseudocoarctation physiology, is that their aorta is almost underfilled because it's sucking so much flow through it. And so and on top of it, you have often some degree of PA hypertension. And so they have right to left shunting, and they need a bit of that right to left shunting to promote systemic blood flow, actually. But the retrograde flow in the aorta is actually because it's being stolen by the brain. And along these lines, many babies with severe HIE who have a lot of seizures and they lose autoregulation of their brain, and they have like cerebral vasodilatation or autonomic nervous system dysfunction, you'll see they have this hyperlucent phase of their brain, which is not something that we desire, but it sometimes happens because of all of these effects. And sometimes you'll see that it's not the PVR SVR relationship. It's because the cumulative territories of vascular resistances will make it that it steals towards the brain, because the vascular resistances in the brain are so low compared to the systemic vascular resistances where the baby's on cooling and vasoconstricted everywhere because of the hypothermia and because of the stress and the all the catecholamines that are being circulated from all the stress that the baby lived. And so you'll see sometimes this either brief or even holos diastolic retrograde flow in this particular context. So that's part of your differential diagnosis. Other lesions like congenital, yeah.
You would have it in seizures too, eh?
Yeah, you see it sometimes. Like for example, in strokes, we see it sometimes because they kind of lose this autoregulation. So you know that systemic vascular resistance is basically your total summative peripheral vascular resistances, but we know all those territories act differently. So your gut may be vasoconstricted, but your brain may be vasodilated. And when your brain is out of proportion vasodilated compared to the rest of your body, sometimes you'll see this flow reversal in the aorta. That's regardless of having a duct or no duct. Like these patients may not have a duct, and you'll see this retrograde flow. It's often a sign that there may have been some brain injury, to be honest. So it's very soft. Like no one has proven that in any literature, but we've seen locally that a lot of these babies that have more burden of seizures, they have that. Okay, quickly, because I want to make sure we go on with the Knobology, but what other what other anatomical lesions you could think would cause a steal effect without the presence of a duct?
Aortic regurgitation?
Yes. Severe aortic insufficiency. You get flow because obviously during diastole your LV relaxes, and your LV pressure typically will go close to zero. And so if your aortic valve is incompetent and you're losing a lot of flow, you're going to see reversal of flow into your descending and also your ascending arch, and everything is going to be stolen into your LV. So that's often something we see more into the adults. So adults that have severe AI, that's one of the signs they're going to be looking at the echo lab. Like, do I have retrograde flow in diastole? That's a really bad sign of valvular incompetency. But we can sometimes see it in some of our patients, especially those who had like aortic stenosis and balloon valvuloplasty in the cath lab, like post cath lab, if they been a bit too generous. And often that's why they're very careful when they're ballooning these valves. They're usually never going to take like balloons that are bigger than the actual valve annulus, because they don't want to end up with the severity of aortic insufficiency, because then you're in trouble, because your cumulative output depends on the fact that the valve is competent. If not, blood flow goes forward and backward. It's just like you want that blood to stay in the aorta to provide blood flow to your organs. Along those lines, and you're probably, that's a very rare disease. I've seen it one case in my life. It's something called an aortoventricular tunnel. So an aortoventricular tunnel looks like this. Aortoventricular tunnel. I have a case in my bank, but I don't have time to open it now. So it looks like this. Oh, that's a nice image. So these tunnels are actually something that comes out above the semilunar valve and can either connect to the LV, most commonly, sometimes to the RV. The issue is that it creates like a free aortic insufficiency. and it steals a lot from the coronaries. So it can deform your aortic root because your LV becomes very overloaded, like the preload becomes very high, and so the stroke volume becomes very high from the Frank-Starling curve principle, and it can cause deformation of this aortic root. And on top of it, you can get some of the diastolic steal that will steal from your coronaries, which can eventually lead to coronary ischemia. So that's not good either. I think we covered all the
Other
retrograde.
thing, Gab, you can see it in severe LV dysfunction.
Yeah.
And
So,
then
and that's typically because you have like a PDA that will retrograde feed your entire aorta. So you'll see this retrograde flow that's happening even in your anterior arch.
and also I've seen it with vasopressin sometimes. So like where you
Interesting.
have like anyway, show me also I've seen it, but because I think like your vasopressin does vasodilate your brain circulation, constrict your systemic. Anyway, I don't want to take too much time, but yeah.
That makes sense. I mean, if you have so much systemic vasoconstriction and then it creates differential vasodilation in other territories. Holodiastolic. There is a section on the website where I put the differential diagnosis. So I'll let you go and read. Oh, you see here, I've mentioned presence of holodiastolic retrograde flow. In this particular, there was no PDA. However, we can see that in HIE with cerebral vascular loss of autoregulation. So that's definitely something. And so it appears like this. You get this kind of flow reversal in the descending aorta. So you can get this image either from the subcostal view, or sometimes you can even get the image from the suprasternal view. So these are all like example where you would use your pulse wave Doppler to get that. But you have to be well aligned. Yes. Retrograde. I think it's in suprasternal. Proposition. Yeah, so this is an example where you would see it retrograde in this kind of from the suprasternal view. And so you will be practicing this when you come and scan with us. So let's go back to the, so we spoke about continuous wave Doppler, pulse wave Doppler. Color, as you know by convention, blue is away from the probe, red is towards the probe. 3D is only when you use an X probe, so either the X7 or the X5. X5 for more adults, X7 for pediatrics. And it's mostly to obtain volumes that we do that because we're looking at more of the functional parts than the actual, in the congenital ward, they're going to use a lot of that for the valvular anatomy, but that's not what we do in our field. You have a button here that's called iScan. I personally rarely use it. Some people love it. It's basically like a button that allows you to kind of optimize your image using AI, kind of. I find sometimes it actually slows you down when you keep on clicking iScan. The other thing is that one of the thing about the Philips that you have to get used to, if especially you scan with other machine, is that in many machine you can use your color box, move your color box, or move your things, and then still acquire your loop from the beginning to the end that you started. Versus on the Philips, as soon as you move your color box, it will restart automatically your loop. So whatever you had prior to that, you will lose if you have not saved. So you have to be aware of this particularity. The final button I want to mention on the keyboard is the zoom. The zoom can be either used by turning the wheel, which will do a zoom, like it will magnify progressively as you turn the wheel. If you use the turning of the wheel method, it will not adjust your temporal frame rate. And so you lose in temporal frame, in temporal resolution. So the best way to use the zoom is actually to click on the button, take your zoom box and bring it to the structure you want to zoom on, and then re-click on the zoom button, which will then allow you to really narrow down the sector around where you zoomed and significantly increase your temporal resolution. That's the only way that you can use the zoom button to increase your temporal resolution. We'll practice together when we scan. Okay? So that's kind of for the overall knobology. I've included in the section on knobology specifics on the actual Philips. You may be using the GE Venue Go during your year at the Jewish and at the MCH. So I highly recommend you listen to the little video where I go over like kind of where to click on the screen to get your actual probes, and that you're going to see that everything of the buttons that I just mentioned, instead of being on a keyboard, they're actually appearing here. So you have the B mode, you have the color, you have the M mode, you have the pulse wave, and you have the continuous wave kind of all here. The other buttons like up, downs, and all these things are going to be on the lateral panel of your screen. For the Philips, if you're going to be adjusting like the up, down button, the up, down option, the reason we would adjust that because we love that in the neonatal space, but there's many conventions on how we do imaging. And so, for example, if you go to the emergency, they'll never going to switch the orientation of the image. They just use one single orientation. If you go to the adult world, they'll never change their orientation. And depending on which pediatric echo lab, like in North America, there's a tendency to change the orientation. But if you go to Europe, for example, they don't change the orientation. What does this mean? It means that by convention, I do probe position, anything that is above the nipple line, okay, your image will be anything that's above the nipple line will have the image with the tip of the pie on top, and anything that's below the nipple line will have the tip of the probe oriented towards down in order to have the anatomical view, quote unquote. The other trick is to think if the tail of the probe is going towards the feet of the patient, it means your image should be kind of flipped up and down. And the reason is really because classically this has been designed for pediatric cardiologists that do a lot of anatomical evaluation. And doing this particular orientation allowed for a more quote unquote anatomical vision of the cardiac structures. And so here what it tells you is that the marker is here, which the marker on the probe is on the left side of the patient. This is the left side of the patient. This is the right side of the patient. So the marker is towards kind of the left elbow of the patient. And so this, is a ventricle that is towards the left side of the patient. And in this particular patient, fortunately, it's a normal heart. So the left ventricle is towards the left side of the patient, because you could have a left ventricle on the right side, which can become confusing, but that's more for the world of the congenital cardiologist. Same thing. So you can use the buttons on the machine to tell the machine, please do an up, down, or go back to the kind of natural presentation. And that for the Philips machine will be on your touch screen. It's typically going to appear here. Here it's written top, bottom. So you would click that and it will change the orientation. In our machine, it's not top, bottom. It's written up, down. It's just because this is for like a breast application. It's the kind of whatever Philips provided me as a PDF. Same thing, you could switch your left and right convention, but we don't do that, okay? You'll see that a lot of the point of care ultrasound application will have the actual marker of the probe on the left side of the screen. For a lot of the cardiology application, you see that's another example where it's on the left side of the screen. For a lot of the cardiology nomenclature, the probe marker is on the left side of the screen. So you see left. So V is for GE Vivid. This is like for Siemens or Sequoia. And then P is for Philips. And then when you have a B is Butterfly. And if it's an M, it's Mindray. So whichever brand will decide to put their little logo and it represents the marker on the actual probe and where it is relative for the anatomy of the patient, okay? The only view where the marker does not represent the left side of the patient, the only view is the parasternal long axis view, where you can see that the left ventricle is on the other side. It's actually not near the marker. So here is the right of the patient and here is the left of the patient. That's the only view where we have this kind of switch of convention. Don't ask me why. That's not what they do in the emergency room. It's just, it happens to be the convention in cardiology. And it's been traditionally that way. And I think part of it is just because of how we hold the probe and how it goes from, so this is my right side, this is my left side. So you have the marker like this, and then you orient like this, and then it goes like kind of, so it's like almost like a kind of full rotation. So for the flow of the imaging, it's kind of easier to do it that way. So I don't know if it's that way. I would have to investigate the reason if really you're interested in learning about that. Okay, 138. That was the part kind of like basic knobology. You'll see that whatever you select on an image, most machine will provide you with a lot of information regarding this. So here it provides you, like, for example, what is the preset, what is the probe you're using, what's the temporal resolution of the image. So here, as soon as you put color box, it will drop significantly your temporal resolution. So example, in 2D, you have 113 hertz, which is 113 frame per second, versus by color, you have 21 hertz, which is 21 frame per second. Then you have the depth. So you see that this image is 1, 2, 3, 4, 5 centimeter from the skin. And this is the scale. So it means this represents 1 centimeter. So if I change my depth and I make my depth much more superficial, this distance will increase between the two dots, right? Because now a centimeter is magnified. So here it tells you it's 5 centimeter from the tip of the probe. It provides you the gain. So here in 2D, you have a gain of 56%. And then you have some of the information of your presets. So what are the information of these presets? What it tells you here is that you're in a general frequency of the probe. Okay, so in Philips, you can decide to go with each probe will have a range of frequency that it can use. And you can either use what we call a range that is more resolution. So it will use the higher frequencies, or it can use like kind of in between, or it can use more a penetration or a much lower frequency to go deeper, but you lose in resolution. So with the same probe, you're able to use something like about 6 megahertz. You can use something like closer to like 10, 11 megahertz, or you can use something closer to 3 megahertz. And so you'll choose whichever you want depending on the image you're getting. And often how you'll do that is that you will be using, where's my wheel? No. Let's go back to Knobology. Let's go back to the keyboard. Yes. So this wheel will correspond often to, you see, gen. So you'll be able to change the either general, resolution, or penetration. So these 3 options in order to kind of activate different range of ultrasound megahertz or frequencies for your actual imaging. So this particular patient, it was a general kind of frequency that was used. And then there's other parameters that corresponds to some of these other things that we're interested in. So compression, the res or speed, activation, that will be written here. So that's this part of this image. When you start having color, you'll have the same thing for color flow. So it will tell you what is the hertz it's using for the color flow, how much gain you have of your color flow. And you can do this also, for example, if you're doing a pulse wave. So if you're doing or an M mode, you see, so it provides you the information about the M mode. So here, my gain for the 2D is 67%, but for M mode is 66%. So you get a lot of these information already on the image of what are the presets that were used to achieve that particular image. It's an example of a Siemens where instead of being on the left side, it just provides you all this information on the right side. Okay, you'll often not look at most of these information, but sometimes it becomes important to look if you want to reproduce certain things in your lab for research, for example, or understand how someone got the information. Because, for example, if I see an image with color that has tons of aliasing, my first thing is that I want to make sure that I'm looking at my scale. Okay, what is the scale I used? Did the person use a scale like 30 centimeters per second? Well, then no duh, I'm going to see some aliasing. Or am I actually using a higher scale? And if I'm seeing aliasing, it means that there's turbulence. It means there's something maybe that's obstructing. Maybe there's hyperflow because there's too much flow going through. So that's one thing I'm going to look at. The last thing I want you to point out some concept is that when you generate ultrasounds, basically what's happening is that the machine will, physiology, ultrasound physics, the machine will generate a current and will pass this current through what we call piezoelectric crystals, or piezoelectric like certain crystals that will create this kind of piezoelectric effect. And what happens is that these vibrations will be transmitted to the skin and to the underlying tissues. And the tissues will eventually, depending on its density and their properties, will rebound. And the machine will have other underlying layers of crystals that will re-vibrate based on the rebound of these waves. And it's the degree of vibration that will be translated into like an energy that will recreate the image. Okay. So you could actually translate that into a noise. That's what we often do in Doppler, right? Or you can retranslate that into like an image, like based on like a color or 2D or whatever you want to reconstruct, or how the machine is able to reconstruct it. But obviously that means that the ultrasound machine had to liberate some kind of force or some kind of energy. And so the machines have certain standards, and probes have certain standards of safety to make sure that the amount of energy that it transmits is not toxic, or it's not going to cause potential tissue damage. Beware, because this is not radiation. This is not the same thing as ionizing radiation that we use for X-rays or CT scan. So if ever there's a quiz somewhere that asks you that there's minimal or not minimal radiation in ultrasound, there's not minimal radiation, there's just no radiation, just so you're aware. There's none. What it does have is some kind of energy dispersion. So you do get often on the screen some degree of information about your mechanical energy that you're transmitting. And often these parameters are bound under certain guidelines that have been established for safety of humans. Okay. And this is what these numbers represents, like mechanical force and TIS, which I cannot remember what it stands for, but we should all know. So TIS, ultrasound, thermal index, there you go. And you'll see that certain probes will become hotter with time, especially when you start using advanced function. So some 3D probes, they may become very hot because they're sending waves of ultrasound in multiple planes. And so they're generating a lot of thermal energy. So the thermal index is important because you don't want your ultrasound to start burning babies. Same thing, the mechanical index, MI, ultrasound, is another element that represents kind of the safety of these non-thermal related energy forces that are being transmitted. So that's pretty much what I wanted to speak about for kind of global ultrasound physics and Knobology. As part of like the requirements of the Royal College, you need to understand a lot of these different characteristics of like how the ultrasound waves, react with the body. How does the machine use that to generate 2D, 3D images? And then some of these elements that you can use to optimize your image. So this TGC, or time gain compensation, is exactly those little things here. So you can have TGC. We used to have something called LGC, which was the lateral. So instead of moving on the horizontal, it was like on the vertical axis. Now, because it's been fallen with all the algorithms to optimize the image automatically, and with newer machines, it's very rare that you have to actually change on the lateral, even often on the transverse. But you still have the option on the touch screen to adjust your lateral. So if really you're nitpicky, you can move your touch screen and you'll have those lateral bands that you can also adjust. But it's very rare we do so in general practice. But these terminology you need to know. You need to know what the time gain compensation, and you need to know some of these other things like M mode, D mode, A mode. Yeah. I think, and I think if you read this resources on ultrasound physics and you go through the module on knobology, you'll probably get a lot of the information kind of summarized for you. These are definitely specific to the Philips. If you're working on a GE, you'll have even other parameters that you can adjust and their own terminology. Same thing for Siemens, same thing for Toshiba, Mindray, and their own different. But they have a different name, but the concepts are pretty much the same. Okay, any question based on all of this?
No, I mean, I think it's gonna come up when I actually scan, like it's gonna be more
Yeah, we're going to be doing
yeah.
scans and we're going to see the different
Yeah.
options. Like, example, we're going to be looking on the Philips. You have the option to also like cut off your 2D when you're doing color so that it really narrows more your spectrum automatically. You have the option of sometimes doing simultaneous, both 2D and color, which it will ask for more processing power, so it will reduce a bit of your resolution on your 2D, but it's still sometimes good. For example, if you're going to want to measure a VSD or a PDA or some of these things, to have both the color and the 2D at the same time, because you're going to be measuring on the 2D.
Yeah.
So there's all of these little elements that we're going to be looking at whenever we're going to be scanning for some of the patients. Okay, so that's the end of like knobology and physics. We have 10 minutes left. I created a little section that I think is interesting. So thanks for answering for your quiz, Laurent. So I give you back your feedback of what to read based on that. I created a new section too, which I think is going to be interesting. So if you go in hemodynamics and you go on your quiz, you're going to see something new that's called quiz calculations. Okay.
Yeah.
And I don't think you should be necessarily answering all of those right away, but I think you should start looking at them and reflecting on how you would answer these questions. And some of them are going to be very easy, and some of them are going to be a bit more complex to kind of think through. And you'll see that I've thrown some of the congenital heart physiology because I think there's a lot to learn from understanding shunts. Because I think if you understand shunts, then you can understand like normal hearts when they have issues and they have a duct, for example, or a VSD or things like that. So you may never have to deal with a patient with pulmonary atresia, intact septum, or with a tricuspid atresia or whatever. But I think if you understand the concept of like flow, pressure, QPQS, and some of these things, it will help you crystallize how to put together like the different chamber, like we said, the flow, the pressure, and all these things. So I'll just give you an example. We'll try to do case one together. I think it's an easy one, if I remember well. So TR has a velocity of 4 meters per second. There's also pulmonary valvular stenosis with a CW Doppler gradient of 2 meters per second. Okay. What is going to be your RV systolic pressure? And what is your PA systolic pressure? The question after is, if you have an aortic systolic pressure of 98, what would be the directionality and the expected peak velocity through a ductus? Okay. So when I speak of these things, is that like completely like Chinese for you, or you get it? You kind of understand?
No. I understand the words.
Okay.
Now I have to sort of figure out how I'm gonna do that.
Okay.
I mean, yes.
So let's do the first one together. So you have a TR jet. So this is a normal heart.
Yes.
Other than it might have some RV flow tract obstruction. Yeah. So you're doing an echo. You have like acceleration through your pulmonary valve. And the first thing you see is that you're getting a TR jet and you get a full envelope, and your full envelope gives you 4 meters per second. So what does 4 meters per second tells you?
But that means I have to do the conversion like with the Bernoulli equation.
So what's the Bernoulli equation?
I would do 4 times V squared, and then I would have the gradient between the RA and the RV, right?
Perfect. So let's go here.
So that's how I would do that first part.
Let's let's go here and let's look at the heart. So your RV-RA is 4 meters per second. So it means that your RV-RA gradient is 64.
Yeah.
Yeah. So what's your usual right atrial pressure?
Like 5-ish.
About 5-ish, right? It fluctuates in time depending on, valvular motion, valvular opening, atrial kick, all these things. So we say 5, okay? Let's say the RA is fine. And let's say the RV is compensating because, with RV outflow tract
stenosis is what's bugging me. Yeah.
Right? So if you have an RVOT obstruction and it's, significant, let's say it would be significant, eventually your RV, if you remember Laplace law, it means that, the RV will be facing significant afterload. And because of that, you're going to have a lot of wall stress. And to diminish your wall stress, your RV will become more hypertrophic. And if it becomes more hypertrophic, your RV is going to be less compliant. If it's less compliant, when the atrioventricular valve is going to open, you're going to have a higher RV and diastolic pressure. And we know that the atrial pressure are the reflection of the compliance of the ventricles, right? Typically, unless you have like a vein of Galen malformation or other reasons why it would not reflect that. So by hyperflow. So, let's say that for now the RV has not remodeled and you're using 5, okay? So it means if you have 64 plus 5, it means what? It means that your RV systolic pressure is how much?
64 plus 5, so 69.
Yeah, 69. So you know that your RV systolic pressure is 69.
Oh, yeah, now I know, I think, how to do the rest, But
so you know it's 69, okay? Yeah. Now it tells you there is a pulmonary valvular stenosis with a gradient of 2 meters per second. So what does this gradient tell you?
But it's pre and post the stenosis. So
right. So your RVPA gradient is 2 meters per second. So if you plug this in your Bernoulli, so it's 2 to the square gives you 4. 4 times 4 gives you 16. We agree?
So the difference would be 16 between RV and PA.
So if you have 69 of RV systolic pressure and you're removing 19, it means that not 19, sorry, 16.
Okay.
Okay. It means that your systolic PA pressure is 53.
Yeah.
You agree?
Yeah.
So you have a PA pressure here in Sicily that's 63. I told you after that, so we know now the RV systolic pressure. We know the PA systolic pressure. If the aortic pressure is 98, what would be the directionality of your duct if you had a duct?
It would be from left to right.
Exactly. It would be from your aorta to your PA in systole. We agree.
Yeah.
Because you just know the systolic pressure. So and it tells you there's some restriction through it, because if it was not restrictive, this duct, then the 2 pressure would be the same. It would be 98, 98.
Yeah.
We agree.
Yes. So it's stenosis, so I have to do the equation backwards, no? For that.
So you have to do
the
equation backward. So you have to do, so we just said it's 53. So you have to do 98 minus 53. It gives you what? It gives you 45. So then you have to do 45 divided by 4. It gives you 11.25. And you have to do square root of 11.25 gives you 3.35. So the velocity through the duct would be 3.35.
I understand.
It sounds ridiculous to do this exercise, but it's going to help you understand, like, what is the TRN telling you? What is the ASD telling you? What is the VSD, the PDA, these equation? I have the aortic blood pressure. I think I can assume what's my right atrial pressure. I know my saturation, my aorta. I think I can assume what's my pulmonary venous saturation. And then you plug your things, and then you're able to understand, because that's the first step of understanding what's happening in the heart and outside of the heart with the blood flows, to then decide, what am I going to do with these? Okay, well, clearly, my aortic pressure is too high. So actually I need to act, like it's systemic vascular resistance. That's a problem. I need to drop my afterload because my LV is failing. So it's kind of things like that that's going to help you decipher a bit more what you're seeing on the image and bringing it to the actual physiological information you want to get at.
Yeah.
So as we go along the year, I think we're going to go like case by case, and then we're going to kind of deconstruct. If you have time to start looking at some of them and doing some of these calculations yourself, I think it's going to be good for you to understand these things. The next class we have together, because let's see, it's 158, is hemodynamics.
It would be in 2 weeks, I think, because next week you're on service.
On service. Yeah, we're on service together.
Yeah.
Perfect. And so the next class we'll talk about some of the physiological concepts.
Yes.
So I've put together, we're not going to tackle all of these, but we're going to try to tackle some of these together and how we spoke already today about like Laplace, so the wall tension and the ventricular adaptation. We'll talk a bit about, and we spoke about Bernoulli. So I know for example, the quiz, I speak about what is some of the assumption of Bernoulli. I think you should know what are the assumptions of Bernoulli and why we should not use it for certain things. So for example, the fact that I made you use Bernoulli for the PDA is actually, many purists would tell you I'm very wrong of doing this. Very, very wrong. Why? Because Bernoulli has to be through one narrow opening. And the PDA is not a narrow opening. It's often like either a funnel or a tube or a serpentine structure or an arc. So it's like a tube or a tunnel. So it's not necessarily like a pinpoint structure. So many people would say that it's mathematically and physically inappropriate to use the assumption of Bernoulli, which is based on a brutal and rapid deceleration at a very narrow point with loss of kinetic energy. So it's all based on the laws of conservation of energy that it does that. And so you don't have conservation of energy if you actually have a multi-stage obstruction. So for example, a hypoplastic arch or a PDA or aortoventricular tunnel, you can look at the directional flow, which informs you, but technically you shouldn't be using velocities of flows because you get, restriction of this velocity along the entire path of the structure. But in practicality, we still often use it, knowing that you're likely under or overestimating this gradient in pressure. So these are like two physiological concepts we addressed today. We're probably not going to address these next week. Next week, we're probably more going to go into like the ventricular pressure loops and understanding how to calculate like QP, QS, and shunt physiologies.
Yep.
That's it. Any questions?
Thank you.
Okay.